Good morning, everybody. Thank you, Annalie. Yes, so as Annalie mentioned, this morning I have the task or the privilege of sharing my journey into PCOS. It's a little bit of an unusual journey in that I didn't fit classical symptoms. So just a first up for ladies and gents out there. This information may contain too much information, and your viewer discretion is definitely advised. So I'd like to introduce you to my family. In the photograph on the left, the little girl on the bicycle happens to be me at around about 18 months. You can see my legs can't quite reach the pedals, and that is my dad. At the time, he would probably have been about 28 or 29. Please take note of the balding hairline. And then his mum, my grandmother, in the right-hand side. So my story starts in Bulawayo, Zimbabwe. I was born, happened to be Rhodesia at the time, and I was born a healthy weight baby of 3.03 kilos at 41 weeks. I was a healthy baby, bottle fed, but with no untoward illnesses, the general childhood illnesses. We moved to South Africa when I was about 5. And at the age of 13, I started my menstrual cycle. And it was 31-day cycle from day one. Every single month, 31 days to the hour almost. I had no PMS type symptoms, and for the most part, no pain. Nothing really to report in my teenage years. At university, I ran 5 kilometers 3 times a week, relatively fit, relatively healthy. I ate really well in my digs. Who couldn't not eat well when most of your digs were dietetic students? And I wasn't really a late night person. I've actually never, ever been a late night person. It's a big bone of contention in our family now, our household now, because my husband very definitely is a late night owl and I'm not. And I wasn't a very big drinker. But the first time the red flag showed was in 3rd year. We did a glucose tolerance test in our physiology prac. And I volunteered to be one of those patients or guinea pigs to do the GTT. And my results showed that I had an impaired glucose tolerance. At the time, I had a BMI of 21. I was wearing a size 6 or 8, depending. Sometimes I was still shopping in the children's department. So the impaired glucose tolerance didn't quite make sense to me then. My whole of varsity, that was what my physique was like, and my fitness and my eating habits were really good. Between my degree and my diploma, I took a year off and traveled abroad and suddenly started to have episodes of irregularities in my cycle, pain. I kind of just put it down to travel, not being in my own environment, the stress of not being at home. I then got back to South Africa and did my postgrad down in Durban. Again, nothing really untoward. Started working at Baragwanath Hospital, which I absolutely loved. Still maintained a very healthy lifestyle. At the age of 26, I went into private practice and started working extremely long hours. I was highly stressed. I was the victim of a hijacking. I bought my own home, my first home, and I started partaking in incredibly high intensity exercise training. In fact, I was training for the 2 oceans. I was dating a scuba diving instructor, which meant scuba diving at least 3 times a month or 3 weekends of the month. And that was 5 dives, 6 dives a weekend, depending on how far we had to travel to get back home. And suddenly, out of nowhere, I started craving sweet things. I started gaining weight. I started to experience far more frequent irregularities, but probably only 2 or 3 times a year that they were out of sync. I was tired all the time. I was an extremely light sleeper. I started seeing in my practice patients referred to me by one of our local gynecologists, and I really loved his approach and his style of communication. After having a relatively bad experience in London, I was very wary. So I booked myself an appointment to see him. And in my first appointment was diagnosed with PCOS and possible endometriosis. That appointment felt like the death sentence to my dream of being a mom. After 3 laparoscopies, a massive stress management course, which I was told I had time urgency perfectionist syndrome, which when we get to SNPs, I'll kind of point out where that might have been coming from. The gynecologist put me onto the pill, and in the first month, I put on 8 kilos with no dietary changes, no changes to my lifestyle. I personally started checking my thyroid. I started looking for antibodies, despite the fact that most physicians and practitioners had told me there's nothing you can do about antibodies. I was training for a 21K race and ended up in hospital with pyelonephritis. And the nephrologist did an ultrasound, and when he happened to be ultrasounding my abdomen, he noticed a massive tumor on my ovary and called in the gynecologist who was on call. That gynecologist said to me, probably from overtraining, that you've developed this tumor. After the treatment for the pyelonephritis, I discharged myself rapidly and took myself back off to my own gynecologist, who then surgically removed a 5-centimeter tumor off my ovary. At the same time, we'd had a urologist diagnose me with interstitial cystitis, which is basically an autoimmune condition of the bladder wall, and the best description is you're allergic to the contents of your own bladder. Because of these surgeries, I ended up with septicemia and ended up incredibly sick in hospital for 2 weeks on IV antibiotics and treatment. In June 2007, I started a trial of thyroid meds after convincing my doctor to let me just try because I felt so bad. My thyroid was dodgy. It wasn't hectically bad. It hadn't failed. But by December that year, it failed completely, and my antibodies had skyrocketed. The phone call that I got from my doctor then is, Nikki, you weren't very compliant in June around your thyroid medication, but actually now you have no choice. Your thyroid needs to be managed. The interesting thing is, I moved down to Cape Town in December of that year. I'd been on thyroid medication for 1 month and fell pregnant naturally after being told by my gynae in my last appointment in November, I'll see you when you're back and ready for fertility treatment. So my little miracle was born in August 2008. So why do I show you these pictures of my family? Well, I know when I was diagnosed with PCOS, I went on this rampant search for research articles to support. And one of the things that struck me was that PCOS genetics, when it's in a male, is associated with premature balding. My father was completely bald by the age of 24. You can see in this photograph, he's borrowing some hair from the one side to make out like he hasn't quite gone bald. His father before him was also. My grandmother on the right-hand side was told she would never have kids. My grandmother, a provincial tennis player in the Western Cape, claims that she had a massive fall on the tennis court, and it was after that that she fell pregnant with my dad. So fertility or infertility and premature balding are linked to PCOS, and that has been my family history and my journey. This is my little gem that was born on the 27th of the 8th, 2008, my little miracle boy, and I believe thanks to thyroid treatment. So when I did my 3x4 genetics test just over 2 years ago, 2.5 years ago, I was expecting to see a glucose insulin pathway, because that is what we are taught, that PCOS is all about glucose and all about insulin metabolism. And when I got my result, I took one look at it and went, so where's this PCOS from? How come I'm battling with it? Because you can see my glucose insulin pathway is a low impact pathway. Delving a little deeper, I started looking at some of my SNPs. And I've highlighted here the DIO2. What we know about DIO2 It is one of the enzymes that is really important, or it is an enzyme in various tissues within the body that is very important for the conversion of T4, which is your inactive thyroid hormone, to active T3. And I had a gene variant. Nobody was testing my T3, T4 ratio until I started studying integrative medicine and found somebody who looked at my thyroid a little bit more holistically. And what did we find? I don't convert T4 to T3. And the minute we started treating me with a little bit more T3, it made the world of difference in terms of my own health, energy, well-being journey. In my high impact SNPs, we can see I've got a COMT. I've got an MTHFR. Yeah, they heterozygote. They're not very high impact, but they're playing a role. And that little arrow to the DRD2, that's probably my time urgent perfectionist syndrome. Just saying. So the article we sent you with this invite showed that twin studies estimate 72% variance in the risk for PCOS to be genetic. There's a genetic inheritance associated with this condition, but it's a really complex condition. So when I've delved deeper into this, I came across this amazing review article that looked at the classification of PCOS. So PCOS phenotype A and B are our classic PCOSs. They have significant menstrual dysfunction. They have an increase in insulin secretion. They have an increase in insulin resistance. They have an increased risk for metabolic syndrome. They have a significantly high incidence of obesity, cholesterol or dyslipidemias, fatty liver or hepatic steatosis, for those of us who want the actual term, and elevated anti-Müllerian hormone. What that means is that the follicle stimulation and maturing is affected in these individuals, hence the fertility associated with phenotype A and B. Phenotype A, usually on an ultrasound, has a string of pearl-like little ovules that are cystic, okay, whereas B doesn't. The incidence or the frequency at which phenotype A is diagnosed is between 44 and 65% of PCOS is phenotype A. 8 to 33% is phenotype B. I didn't fit in this classification. That made me really frustrated. Phenotype C is also known as ovulatory PCOS, with a mildly elevated serum insulin, mildly elevated cholesterol, mildly elevated androgen levels, but a very high hirsutism score, hence her mustache. Metabolic syndrome in phenotype C is very common. In fact, an Italian cohort showed that ovulatory PCOS was associated with socioeconomic status and the eating habits associated with those individuals. Phenotype D, non-hyperandrogenic PCOS, which means normal androgen or male hormones. So no moustache. In fact, my own journey, again, warning, too much information, I don't grow underarm hair much. And let's say a bikini wax is really a waste of money for me. Slightly elevated endocrine levels, the lowest metabolic dysfunction, elevated sex hormone binding globulin, but a low T3 and T4. Hey bingo, hey presto, this is where I fit. This is a thyroid-associated PCOS. These individuals also usually have a low LH to FSH ratio, and their menstrual cycles are normally really regular. And that was something people always used to say to me, but with PCOS, you shouldn't be regular. I'm like, yeah, that's what I've heard, but I don't fit that. My cycle from day one was 31 days, including from 6 weeks after having my son, in spite of having exclusive breastfeeding. I'm really jealous of those of you who didn't get your period for the time that you were feeding. The incidence, however, of this phenotype is 0 to 23%. It is the more rare of the phenotypes of PCOS. What I'd like to do now is I'd like to hand over to Dr. Estia Udendal, who's going to take us through how to diagnose PCOS, or how she diagnoses PCOS in her practice. So Estia, if you would like to share your screen with us, because I know you have a few slides, and take yourself off mute.
Okay, Nikki. So you know my story, that I'm a gynecologist. I'm trained as a gynecologist, and then I've got a special interest in more integrative, more holistic medicine, just because I do find that we have, after all the years, we don't have the answers in conventional medicine. So when we are presented with a patient with the classical symptoms of polycystic ovary, they present with hirsutism, they've got coarse black hair, they've got acne, then it's quite an easier diagnosis. Or if you do the biochemical studies and the testosterone is high, the free androgens is high, or there's insulin resistance, then it is an easier diagnosis. Like in your case, Nikki, much more difficult. And that is definitely the phenotype that we overlook. Then the patients can present then not just with the androgen problem, but also with ovulatory dysfunction, meaning they have very scanty periods or irregular, they do not ovulate, and they present very often with fertility issues. Important that these patients get an ultrasound, and like Nikki said, they've got like a little pearl, a necklace of pearls in the ovary. So we look for that follicles, and just remember the phenotype B got all the symptoms, but they do not have the sonar picture. So we diagnose polycystic ovaries when we've got 2 or 3 of these bacteria, and we must exclude whether there's not an adrenal problem, thyroid, or then whether there's perhaps a high prolactin. So let us just move on here. So when we look at the treatment, yes, we've got the 4 phenotypes, and I think before we delve in there, you must always realize what is the patient's expectations and what is your expectation. Because a patient presenting with you with severe acne, hirsutism, overweight, but all she wants is a baby, that's her expectation. Your expectation might be something completely different. So it is important just trying to merge those two so you get the patient compliance. And then our treatment, old school, is that we focus on the ovarian dysfunction. So we're trying to get the hormones better into an ovulatory state, and then we must focus on the metabolic influence and the insulin. But there's a new school of thought that this is also, again, inflammation may play a role. So there's already a group in India that talk about the inflammatory PCOS, where there's a dysbiosis, and they can trace it back to the embryological state of the fetus, and where the baby is exposed intrauterine to certain androgens. So when I looked at the treatment, because now Annelie said, there's now 4 phenotypes, how are you going to manage it? So I went to research, and I found this. That's the international guideline how we manage polycystic ovaries. 201 pages, I kid you not, 3,000 contributors, and in that 200 pages, all that they advise the people to have is the pill, which may or may not work. You can give metformin, but be careful, it's dangerous. And then Clomid, we must give for the you want to fall pregnant, and just maybe inositol may work. So that is the treatment you're going to get from your gynecologist. And with everyone on a call, I know you've got a completely different approach, and you've got much more experience in the integrative side than me, but I will try to share with you. So that is the mainstream medicine. And then you've got the different approach, which is then more the functional medicine approach, which then, and this is a slide by Dr. Sarah Godfrey, she's from Metagenics Institute, and there you start off with a lifestyle. Yes, I will talk to us later about the diet, and then very important, the myo-inositol, which is then helpful with the insulin. Now, interesting enough, one would think that phenotype D, where there's not that hyperinsulinemia, actually do not need inositol, but there's enough studies to show that it even benefits the ovary to give them, to give those patients the inositol. And then just your standard treatment, magnesium, omega-3 for your anti-inflammatory response, and then berberine. So this is your core that you then look at. And then specific treatments that is then targeted with your nutrition, your magnesium, your zinc, the role of resveratrol to decrease the testosterone, quercetin as well, curcumin also important for the inflammation that it reduces, and then your acnes castus. So you can see all of these, so what one can consider supportive things do play a role, because it balances the, first of all, the help with the insulin. If you've got the insulin pathways better, the little theca cells in the ovary will produce less testosterone. If you get the insulin lower, also beneficial effect on the sex hormone bindings globulin that can gobble up the free testosterone, so you have less facial hair, less acne. And then we're also addressing the inflammatory response. And then I like acnes castus because that's the only medication that we have that can balance the FSH-LH centrally. Because remember, in polycystic ovaries, you've got the reverse ratio of the two hormones, so that is important. So after showing you all of that, what do I do? Very simple. I think sometimes we get so hooked into all the information, and there's so many stuff out there, and I do not have any affiliation with any of these medications. It's just the slide was very empty and I needed some color, so we put that on. I don't have any financial incentive to advertise anyone. So my approach, once I've diagnosed, is I would all of them start them on inositol. I like to use a product that just contains everything. It's easier for me. I like the Insumax because it does not contain the sucralose like the Picositol. I don't know why the sucralose is in there. Can't explain that. You also use antigolan. And then there's a lot of other inositol products. But I think very important to motivate the patient, go onto inositol. Like that, you take care then of your metabolic and the side of things and the insulin. And then all of them, I give acnes castus. So you're balancing the hormones centrally. And then I recently started working now with berberine as well, which then address the inflammation. So that's the bottom line. That is where I start, without fail, every patient. I've had the patient 10 years infertility with PCO, and I've just started on the inositol and the acnes castus, and after 6 months, she conceived naturally. So sometimes we're lucky, sometimes we just need to have the right combination. So that's where I start. And then into specific treatment, 2 scenarios. If it's a young patient, she presents with acne, she's desperate, the face must be better. One can start on an other contraceptive pill, but be careful with the SNPs. You may not tolerate the other contraceptive pill. Like Nikki picked up 8 kilos in the first month, and that's a real problem. Can happen. If I can tolerate it, obviously, Diane, jasmine, they are the better ones for the skin. If I struggle with that, I will go to Clara. Clara and Zoli is the only two other contraceptives that actually contain the natural form of the estradiol and not the ethanol estradiol. So Clara and then the Zoli is better at that point. If we still struggle a lot with the hirsutism and acne, one can add androcur, which will then block the testosterone. Then I put a question mark with metformin because that is still very controversial. I very, very rarely use that. I would keep that just for the patient who got a higher glucose. I will not use that for the patient that just got hyperinsulinemia. I think it's the wrong drug to use for that. And then for severe hirsutism, one can then add the spironolactone, which is a type of a diuretic. So if you then look at your older patient, she's now 45, or let's make it a little bit younger, 40, had the sterilization, but now she's not having her periods, and then after 6 months of amenorrhea, then she's got severe menorrhagia, flooding, and on sono you see that polycystic ovaries. She still struggles with acne. I think this is the patient that be careful when you just start to introduce medication in that one. I've had a lady of 36 with endometrial cancer. So just be careful. The patients must be evaluated with a sonar. So that's just a little red flag. If they are anovulatory, the endometrium undergo hyperplasia, meaning it gets thicker, and that can then convert into cancer. So, oh, I like that. I don't know how that happened.
Apologies, we had it happen last week as well, so
I
don't
like
worry.
that. I like that. So they'll keep it there.
Nobody's drawing. Apologies.
And then, so for these patients, we're looking then more at the estrogen dominance effects. So use your sulforaphanes for IPC. And then it is important that these patients must have a withdrawal bleed. So for them, I will put them on a bioidentical progesterone, which is then either formulated in a capsule or then in a cream. And then just for a last slide, for our fertility patients, also we have limited options. And for those patients, we start with ovulation induction with clomiphene, but typically the PCO patients do not respond well. That is the problem. So it's also limited. Ovarian drilling that we do under laparoscopic surgery is literally just to pop the little cyst. That can have a beneficial effect, but our options are still limited. Okay. I'm happy to take any questions at the end or now, just like to want to.
Lovely. Thank you, Estia, for sharing that with us. It was really, really helpful. And yes, if you have got questions for Dr. Estia, please do pop them in the chat. Tyson is continuing to watch our chat box for us so that we can ensure that we cover all of those. So just going back to the phenotypes. So in our article, the phenotypes were classified like this. Phenotype A, the ultrasound with numerous polycystic ovaries, anovulation and hyperandrogenism, where phenotype B, a normal appearance of the ovaries. So sometimes your patients will say that the doctor didn't see anything on the ultrasound. That doesn't mean that they're not PCOS. On the phenotype C, ultrasound, polycystic ovaries with normal routine menstrual cycle and hyperandrogenism, and the D, the polycystic ovary with oligo and ovulation without hyperandrogenism and androgenism. Okay. So from just a reminder, this is the article that we sent you. So it should have been, you should have received the link to be able to download it. It is a great article that really does look at the genetics and the SNPs associated specifically with PCOS. And this particular diagram in the article I really loved because it shows which SNPs are associated with which specific function within PCOS or malfunction within PCOS. And what you'll notice is that the 3x4 genetics test doesn't necessarily have all of these SNPs. It's got a lot of them, so you can already start using. But I'm going to ask Annelie now to talk us through what pathways should we also be keeping in mind when we have a PCOS patient in terms of correct treatment or management of that patient. Thanks, Annelie.
Thanks, Nikki. Thank you. So that was really interesting. Thanks very much, everybody. So I'm not going to take too long. I just want to remind you that, remember that PCO, you get PCO and you get PCOS, which is a syndrome. And this is always where your genetic report comes in so helpful, because you can then go back to the report and see, remember last time, for those of you who watched our insulin resistance talk last time. So if you go and maybe you don't see exactly what you expected, and you look at the genes, maybe you can see that there's a high impact in the insulin pathway. Or sometimes you expect, so I've often had it, Nikki, where people arrive and they have PCO and we get the report and there's nothing, the hormones is not highly impacted. So from my point of view, you actually can't leave anything out. You want to look at what's going on in all the cellular pathways, definitely what's going on in inflammation, what's going on in oxidative stress, methylation, and then in your systems, definitely immune hormones, and especially if you, like Esther said, if you're starting to consider using contraceptives for treatment. So the genetic pathway can definitely also help you to decide the best treatment, and also what other supplements maybe are missing. Then definitely your brain health pathway. We know there's a lot of depression, so don't forget about that. We know about that. We know there's also side effects later on in terms of vascular health, high cholesterol, and also the energy pathways. So if you look at the energy pathways, you want to make sure that you also assist them with weight problems, because, and I also often find people come to me, oh, I've been diagnosed with PCO, but I don't have weight problems. And when you look at the report, then you often see, well, then they were lucky they didn't have those genes on top of it. So that's really what I want to say right now, and also we'll take questions later. I just quickly want to show you guys, we put a tool together to use as normal. We're going to try and give you a tool every time. So Nikki's going to just go through the next slide, and we're not going to spend too much time on it because we still got 2 guests, but just to page through it, this is for you to use a lovely tool to remind you what the diagnosis is, the incidence, which genetic pathways to consider, and also some high impact SNPs to just go and look at in your genetic summary. And just remember to go look at those genes, because those are the ones, that's phenotype B. And phenotype C, you'll see there's the moustache, and,
yeah.
and then phenotype D, which
I just want to point out here, in my report, so I have the MTHFR 677 in a high, I have a COMT in a high, and I have a DIO2 in a medium. I luckily don't have an FTO or an IRS, and I've got some protective GSTs, which is great. But this tool really did help me from a point of view of trying to target, okay, so which SNPs in our report actually point me in the direction of how my PCOS comes about. PCOS is an incredibly complex condition. It is not a one-size-fits-all pathway, which we can see purely by looking at these phenotypic classifications. Thank you, Annelie, so much. So let's call up our next 2 guests. So we're going to have Claire first, because it's alphabetical order. Claire Yulsing-Stradum is definitely not somebody that needs much introduction. So Claire, if you could turn your camera on and your mic on. And what Claire has been involved with Delfran is developing the PCOS micronutrient multivitamin mineral supplement targeted specifically to PCOS. And we've asked her to just talk us through a little bit of her thinking of why she chose the ingredients that she did and the format that she did. So Claire, welcome. Thank you very much for joining us. Thank you for your time. We really appreciate it. So Claire, I'm going to stop sharing my screen so that we can see you better.
Okay.
Awesome. Okay.
Thanks.
So if you can chat us through the picositol.
Yes. Nikki asked me to share a little bit of my story as well, and I actually said to Nikki, I developed picositol for me. Actually, is how it all started, because I was diagnosed with PCOS in my teens already. Well, they didn't diagnose it then. They obviously got it completely wrong. Put me on Diane, also picked up weight, got the acne, the whole typical. I'm more a type AB PCOS with all the terrible genes that you don't have. Nikki, I tick those boxes quite well. So the reality is that you've gone all these different meds, and the more I started reading about PCOS and the more I started treating patients with this condition, obviously having it for myself, number one, I realized my compliance wasn't good, because the tablet load became too much for me, myself, and I saw the exact same thing happening with patients. So the first thing I want to say is, I also knew that, for example, the B vitamins weren't methylated in the products that were available. There wasn't the D-chiroinositol available in the products. It was just the inositols, not the D-chiroinositols, and I wasn't being compliant. So I went to Delta and I said, please, can't we make, like, why can't there be a better product for women with PCOS in South Africa that's not going to cost a lot, because the cost also racks itself up. So I was going to make a couple of first key statements before we get into it a bit more. But I developed PCOS because it's all not to be a baseline multivit. So you would still use a baseline multivit with this product. This is really to target specific nutrients that have a role to play in the PCOS picture, so that women don't have to take individual single high dosages to keep those levels in check. Like you'll see, for example, on vitamin D, I use 1,000 IUs. That is almost like a maintenance dose, because most of these women do get low levels, but once you get it up to 60, 80 on the vitamin D, then this will at least help to maintain that. But that again, the cost became too much for the patient, and even for myself, the tablet doses were too high. So the first thing I want to chat about is just the decision on the inositols. There's a lot of literature looking at the dosages of the inositols, and the clinical outcome seems to be better when you're taking a 4-gram dosage of inositol. So the other thing was that you get the combination with the myo-inositol and the D-chiroinositol. They also showed that combination therapy with the myo-inositol in the D-chiro restored the hormonal and metabolic parameters a lot quicker than if you were just using inositol on its own. Now, what we need to understand with the inositol combinations in PCOS is the inositol improves the insulin sensitivity, also the plasma insulin levels, HOMA index, the ratios get improved, the prolactin and the testosterone can all really be improved with the inositols. And the thing with PCOS, with the D-chiroinositol, your myo-inositol can convert into D-chiroinositol, okay? But the problem with PCOS women is we have like that whole pathway, or whatever you want to call it, doesn't work well. We overproduce on the D-chiroinositol in women with PCOS. So what happens is, when we get these higher quick conversion, it actually worsens the egg quality. So what they're saying in the literature is we want to use a 40-to-1 ratio with the myo-inositol and the D-chiroinositol. So if you're using 4 grams of inositol, then your myo-inositol should be 100 milligrams. So you don't want to take a supplement with high-dose D-chiroinositols. If that 40-to-1 ratio is out, it can actually worsen the egg quality, and it's very important to keep that in mind. So they actually found by giving the woman that dosage already in a 40-to-1 ratio, that is the correct ratio that you want in human physiology, it stopped the woman from overconverting the myo-inositol to try and make this D-chiroinositol, and had better outcomes because that ratio was already corrected. So that was the reason I specifically put in the D-chiroinositol. And like I said, the benefits are regulating menstrual cycle, promoting ovulation, better egg quality. They also found it reduced carb cravings, reduced risk for gestational diabetics, and then also insulin, glucose, cholesterol, inflammatory responses were all reduced with that combination. So Estia was saying the inflammation part is also a big contributing factor. And from that perspective, there's a very good paper, and I'll share the reference with all of you. It's one of my favorite PCOS papers, and it talks a lot about inflammation. And the vitamin D there is massive, because it binds those glycated, the reactive oxygen species actually get bound by the vitamin D. So we want to make sure we've got the high dose vitamin D. So those are the myo-inositols and the D-chiroinositol. I'm not going to speak too long because I know I've got a short little slot, but I also put a lot more magnesium in, and I also put magnesium glycinate in, which seems to be the better version of the magnesium to use. And I went with a much higher dosage, because your PCOS women have a much higher chance of having magnesium deficiencies. In myself, if I do not take my stuff regularly and I recheck myself, my magnesium has gone down, my B12 has gone down, my vitamin D has tanked. I get vitamin D of 7 if I'm not keeping it. Like, I just have to be on it forever. So I also work, I've got a functional medicine endocrinologist that helps me with my PCOS, and you know, I can see when I haven't taken my stuff properly because they just all completely go down. Then I also put folic acid in, and I used obviously the methylated folic acid and methylated B12. Women that are taking metformin, which there are lots. I mean, so the reality is a lot of patients that arrive in our office, or even the patients that are never going to see a dietitian or never see a functional practitioner, I just thought to myself, the vegan people with an MTHFR gene mutation that will never ever cross my desk or cross any of our desks. They just don't have the funds to do so. So I just put methylated folic in and the B12 right from the word go. And just another interesting little quick story. My sister actually couldn't fall pregnant after 4 years of fertility treatment. And Annalie actually really helped me with this, but they said it was actually with the NCHFR, and she needed high-dose methylated vitamin B12, and we put on low-methionine diets, and we got her homocysteine right down to 6, and she actually fell pregnant like that eventually. And there's one paper on this in the whole of PubMed, one paper. So for those reasons as well, I use methylated versions. There's also chromium and there's zinc oxide, and I also put calcium in. So the calcium wasn't a big thing for the PCOS for me, but these women also do need that baseline calcium. So for me, that was a cost thing again, that I did that for. And then there's also coenzyme Q10. Just to chat to Estia's question about the sucralose. So obviously, if we could do 0 sugar, 0 sweetener, 0 anything, that would be amazing. But the problem is, and I learned this the hard way, as a dietitian, you come with this little bubblegum unicorn dream of what you want in your product. I mean, there were other things I also wanted. I wanted to put NAC in it. There were things that were like, sorry, Claire, you can't do all those things. And I'm like, can you make it bubble? I want it to be like a Barocca and bubble. They're like, no. So it's when you have an idea of what you want a product to be versus what you can actually make, that's two worlds apart. So from the sucralose perspective, it was a taste issue. Stevia would have probably been a better solution, but the taste profile was terrible. We tried a different one and the stability wasn't good. So it took 3 years to actually just develop P-Cositol and get it on the market. And as a dietitian and a woman with PCOS, and someone that treats women with PCOS, the main objective for me was to create a product that we could be all in one. The magnesium makes it a bit milky, so that's why the taste profile had to change. But yeah, it was to have a product that women could take 1 sachet a day and 1 baseline multivit and really have a very full, comprehensive nutrient profile that would hopefully maintain their health and help them with the PCOS. And I've been using the product in my practice now, and I've had really good responses. So that obviously is very nice for me to see the benefit. And just to give you a bit of background on how to produce. But I'll stop there because I'm talking too long. So thank you, Nikki.
Okay, lovely. Thank you so much for sharing. I think it's really good to get some insights in terms of what your thinking was when you developed the product. So thank you for sharing that with us. Next up, I want to invite Marianne Duplessis, who is the CEO of MNI. And as Annalie mentioned, she's an award-winning pharmacist. MNI have recently launched Ovivance, which is also a product specifically for PCOS. So welcome, Marianne. And if you could just give us a little bit of insight into your development of your product and why it was that you chose what you chose to put in, that will be awesome. Thank you.
Thank you very much, Nikki, and thank you. I would just like to start to quickly just give you a little bit of background of MNI. You know, we have a very special interest in a metabolic syndrome. Our whole approach is preventative medicine, supporting and trying to alleviate all the conditions related to the metabolic syndrome. We really believe in a holistic approach. It's not just drinking a pill. We all wish we could just drink a pill and everything will be fine. It doesn't always work like that. And I think when we start to look at your PCOS and infertility, those patients are usually very desperate, and they would love to have a solution that just is like a quick fix. So I think when we've developed specifically Ovivance with all our other products, we always look in people drink all sorts of supplementations, all sorts of prescription medications, and you are not always aware of what they are taking. So I think it is quite responsible just to always be aware of all the combinations that patients can take. Most of our products are combinations of herbals, vitamins and minerals. We believe you need less, you get a better outcome because you combine it, they work synergistically. And then you can also, in a way, manage the side effects and possible contraindications with prescription medications. Now, PCOS is a very complex medical condition, like we've just heard. Part of the metabolic syndrome. Unfortunately, it is not a simple solution. We believe, once again, a holistic solution and see what we can offer. So, yes, we've developed Ovivance. It's in a tablet form. It contains your 40:1 inositol ratio. We've got the folate, the choline, vitamin A, B6, B12, vitamin D3, iodine, magnesium, selenium, and zinc. So we've developed a product that we can believe that can support that patient, that will help that patient before as well as during pregnancy. But another thing that we found is very important is it is quite a stressful time for a patient to be in because of all the symptoms. If they're desperate to fall pregnant, they experience a lot of anxiety, and that's the last thing that you want. So we like to combine Ovivance with Neurovance, for example. Also for the husband, he's sometimes also under a lot of pressure, and the poor guy also needs some support. So Neurovance is a very nice combination. Then for your overweight patients, your obese patients that have insulin resistance and maybe some of the other metabolic syndrome conditions, is a very nice combination to combine Ovivance with your Untitled, if you wish. Then your teenagers and acne. We've developed Skin Bonds and Zinc combination. It's the basis principle of Ovivance. It's in a little bit of a lower dose, but with extra zinc. And that's actually a very nice product to start your teenagers that wants to control your acne type of symptoms related to possible early onset of PCOS. Inflammation, you've mentioned inflammation prior. Absolutely, it's a big thing when it comes to the metabolic syndrome. There we have Flamly, for instance, that contains curcumin and boswellia. So it's just a very nice product to bear in mind if you wish to treat that inflammation as well. But just back to Ovivance. Ovivance is our new baby. We're getting very good results. But once again, we like to combine it with a meal plan. We like to advise them to look at their exercise, to look at their general health. PCOS might be one of the symptoms of a metabolic syndrome. And as you know, there's a lot of complications if you don't treat it well in advance. And the good news is you can do so much for that patient. So that is really in a nutshell what and how we've developed it.
Awesome, Marianne. I really love the fact that you've got a Skin Vance, because Ovivance sometimes to a teenager means we're trying to make you ovulate, and they probably have a little bit of a mental block against that. So, or it speaks to fertility, and it's definitely not something they necessarily want to go on that journey with. What I also loved about your Ovivance is it spoke a lot to me to the thyroid, so to the phenotype D, because it's got the iodine, the vitamin D, the vitamin A, the selenium, the zinc, which are all cofactors for our thyroid enzyme conversion from T4 to T3. So just because we've got two products doesn't mean we can't use them both in our practice. We might use one for one type of patient and another for another type of patient. Marianne, thank you very much for your time. We really appreciate it. Do hang around for the next 5 minutes, because if we have got any specific questions that are going to be targeted to you, Tyson will be directing them your way. So thank you. Thanks everyone for joining us. And I'm going to hand back to Tyson and Annalie to close up.
Awesome. Thank you so much, Nikki. There were a couple of questions that came through that were answered during the course of the presentation, which has been great. I do know Annalie got one that she just wants to put forward. So Annalie, over to you.
Thank you. So just for you, this is for you, Estia, if you're still there. So can you give your opinion on the FSH-LH ratios as this is a key biochemical indicator. This was from David Arthur. If you could maybe answer that for us.
There's usually if we check a hormonal profile and you do it in the early day 3 of the cycle, you will have a higher FSH and a lower LH, and then just about 24-36 hours before ovulation, that is when the LH will peak. But in the polycystic ovary patients, there's the inverted ratio. So your LH will already be high in your follicle phase of the cycle, and the ratio is about 2:1, LH to the FSH. Hope that answers your question.
Thank you so much. That was very useful. I think we need to have STO for much longer periods on these. You muted, Nikki.
Absolutely, I couldn't agree more. Learning from our practitioners who are working in that space is just, it's invaluable. So thank you very much.
Awesome. I think that is all. In fact, hang on, there's a question that's just come in. A question from Dr. Feroz. Should we use Vitex in the luteal phase of the cycle to enhance progesterone production? Estia, I'm sure you can answer that one as well for us, if you don't mind.
Hello. Yes, I'm back. Now use the Vitex Acnes actually right through the month. It is actually unbelievable if you start using the Acnes casters any other time of the month, but on the first day of the period, then you will actually change the cycle. So it does have an influence. So and that's also a good one to explain to the patients, because sometimes they believe the natural things cannot work. So they must start on day 1 of the cycle, and then they must carry on right through the month. And that is the best way for that one. And then I can just say, you talk about the practitioners working with this. I just want to tell all of you, this is the most empowering 1 hour learning, and to start learning out of the box, and just all the tools that we can use then to support our patients. Because like I showed you, out of that 200-page manuscript, there's not a lot of tools that we have to support this patient. So thank you, all of you.
Thanks, Estia. I also want to make a comment that what you said about the Angus casters, I think sometimes practitioners and patients think that if you take a herbal supplement, doesn't matter. I had a patient who stopped and started, and it was something that had Angus casters in it. And then she couldn't understand why she had this abnormal period, and things went haywire. So I think that is really, really important point about knowing that it's not nothing, that if it's natural, it still has an effect, like everything that we do.
Absolutely. 100%.
Awesome. Well, thank you so much. Firstly, a big thank you to all our speakers. Really, really appreciate you guys giving up your time and sharing your knowledge with us. And I'm sure all the other attendees do as well. Thank you, obviously, Annelie and Nikki again for hosting us. And guys, the next one we're going to be doing is going to be on the 2nd of September, and it's going to be focused around sleep. So it'll be quite a useful one, I think, especially during times of lockdown where people are not sleeping because kids are homeschooled. But yeah, please stay tuned for the invite for that, and we'll see you all in 2 weeks' time. Thank you so much.
Thanks, everybody.
Thank you, everyone. Thank you, Marianne. Thank you, Claire. Thanks, Estia. Bye.